Welcome back, welcome back. We are finishing an exciting afternoon and a thought-provoking one with more thoughts on the future. And I'm absolutely delighted that Professor Jane Wilkinson is joining us from Southampton, because we're dealing with the new NHS workforce on a daily basis and seeing what the changes are going to be, and thinking and anticipating ahead is going to be so useful for our daily work, and anticipating how it's going to impact our collections, our space, and our workload and everything else. So I'm delighted, and without further ado, I'm going to just pass over to Jane because I'm dying to hear all about it. Thank you so much. We'll keep all the questions to the end. That's
Fantastic. Okay, well, thank you very much for inviting me. So I think the invitation came predominantly from Rick, who I've worked with for many years in varying capacities, on my part anyway. So I'm honoured to be invited to talk to you, and just like to sort of issue a health warning with this talk. It's very much a personal reflection on the implications of the long-term workforce plan, impact on higher education institutes, but also impacts on our NHS partners, because when we're delivering a medical school programme, we are working with NHS partners very, very closely. So I don't really differentiate between the impact on us as a university and a faculty of medicine in Southampton and our NHS colleagues who host our medical students and other allied health professionals all of the time. So this is very much my personal view, having just sort of embarked on the process of considering how we in Southampton are going to adapt to the NHS long-term workforce plan. So as you can see, I'm Associate Dean Education in the Faculty of Medicine, but for most of my working life, I've been a practicing respiratory consultant at the University Hospital of Southampton, and that's where I first met Rick. I beg your pardon, Rick. That's where I first met Rick when I became involved first in clinical teaching on the Bachelor of Medicine programme, and then I took over as Year 3 lead, so I led the first clinical year of our BM programme, and then I took over as programme lead for the 5-year programme, and I took over as Associate Dean Education in January 2020, which was not the most auspicious time to take over the running of a medical school, just as COVID was about to strike. So it's been a challenging few years for me. And now our new challenge is to step up and try and address how we're going to implement the NHS long-term workforce plan. So the three in the document, I'm sure you've all read it, but in the document written by the head of NHS England, these were the three priority areas that were identified, and I don't think any of us would disagree with them. They're fairly self-evident statements that we need to increase education and training across all health professions, not just medicine. So train. We need to retain, and that's a big issue at the moment. So the workforce we train and the workforce we've currently got, we need to hang on to. And that, as I'm sure you're all very well aware in the current political landscape, is a very hot topic. How do we justify the investment in all of that training if they then either go and work abroad, leave the profession altogether, or just stop working? So that is a big issue. And I think the last one, which is reform, is probably the most difficult to pin down in terms of what that actually means, because in my view, reform often means trying to do more work for less investment. And that's a rather cynical view, but trying to increase productivity by using new technology and supporting staff in becoming more flexible in their skill set. And I think there's some double think there, which makes me a little bit worried. Flexibility, new technology, improving productivity. I think that means shrinking the workforce and expecting them to deliver more, although of course they're trying to expand the workforce, at least in the early stages of training. So I think that it is really clear what the cost of inaction will be, and this is a headline in the long-term workforce plan document, which is, we know that the population is aging, and that the number of people aged 85 and over is estimated to grow by 55% by 2037. And with that will come a considerable amount more complex comorbidity to manage. Obviously, we want to try and ensure that people grow older and live well, and that people remain independent and physically and mentally well for as long as possible. But it's inevitable that with an ageing population, the demands on the health service will grow. And it's estimated that if we do nothing, there will be a shortfall in the number of healthcare staff to support that ageing population of about between 260 and 360,000 by 2036-37. So I find that figure quite terrifying, because I will be one of those people, not quite over 85, but I'm in Sniper's Alley. I feel I'm in Sniper's Alley already, and I really want to be confident that there's a competent, well-trained workforce of healthcare professionals that are going to be able to look after me and my family when I need it. And at the moment, I have to say, my confidence has been shaken, so that's a concern. So with respect to medicine, which is my main area, I don't look after health sciences, so I'm not responsible for the training of nurses or other allied healthcare professionals. With medicine in particular, the aim is to double the number of medical school places from 7,500 to 15,000 by 2031. So that's a massive increase. And it goes beyond what the Medical Schools Council proposed in an early document when Malcolm Reed, who's a surgeon who leads Brighton Medical School and who chaired the Medical Schools Council Education Leads Group for some years, his document, which was presented to the Department of Health, suggested that we needed to expand the number of places by 5,000 to meet the workforce needs of the future. So this expectation of doubling the workforce by 7,500 exceeds the request that came from the Medical Schools Council. And the plan is to make those first places available from September 2025. And what the Office for Students have said is that they are initially releasing 350 of those places, which will be allocated for entry in 2025. And Southampton has bid for a proportion of that 350. So all of the bids have now gone in. The closing date for applications for those new places, that first tranche of 350 has closed. And we will know whether or not we've been successful in that bidding process, I suspect by around April time of this year, because we have to be able to start recruiting for those students when we open our recruitment round for 2025. The closing date for applications will be in October of this year. So I suspect we will find out quite quickly. But then we'll increase by 10,000 by 28-29, and we will complete the process of increasing by 7,500 by 2030-31. So 350 seems a relatively unambitious start, but that's because I think many other aspects of the long-term workforce plan have not at the moment been really thoroughly and comprehensively worked through, and much of it remains aspirational. So 350 seems a modest way to start. What we also don't know is that whether the process of places being bid for, or whether the process will change to a commissioning process. We don't really know how the rest of it's going to work as yet. There's been talk of the remaining places being commissioned rather than putting us through this bidding process, but there's no real clarity, as far as I'm aware, of what the next steps for allocating places will be. And there's been some guidance from the Office for Students about on what basis they will award extra places to medical schools who choose to bid in this first round. And some of this, I think, bears closer scrutiny. So, for example, applying innovation in course delivery. And I think that's a tacit acknowledgement that we cannot deliver medical education in the way that we currently do and expect it to work with those increased numbers. We have to think about different ways of doing things. So I completely support the idea that, that we will need to be innovative. How we're innovative remains to be seen, and I've got some ideas on that. But I think there's no doubt that we cannot carry on with the existing model, which is still largely speaking some preclinical stuff followed by more intensive clinical placements out with NHS providers in the latter stages of a medical school programme. And that isn't going to work if we want to expand in the way the long-term workforce plan suggests we need to. The other bit of guidance is that the curricula that are offered, or the medical school programmes that are offered, will be chosen on the basis that they prioritise primary care and other shortage specialties. And one of those shortage specialties I would suggest is going to be psychiatry. So it's areas where the NHS is struggling to recruit, or which need significant expansion to manage the healthcare needs of particularly an increasingly ageing population. They also want to consider accreditation of prior experiential learning programmes. So there may be people that have done programmes in other disciplines that are healthcare related, where that learning can be recognised as an entry requirement into perhaps a shorter medical programme. But again, there's no real clarity on that. They are very keen that we develop apprenticeship models of training, and you may or may not be aware of those, but that is a thing that's been very heavily promoted by NHS England. And that means that trusts, or NHS trusts, will partner with a higher education institute to offer a programme as an apprenticeship model. So the students will work and study in order to meet the same standards that are set by the GMC, and they will need to pass the same exams, but they will do a very different programme such that they are working and earning money and not paying tuition fees as they study. And again, it does require a partnership with an HEI, but the training is delivered by an NHS trust in its entirety. And I'll give you a little bit more information about that in a moment. They're also keen that we shorten the programme. The traditional school leaver entry programmes are traditionally 5 years long. In some institutions where there's a compulsory intercalation year where students opt out to do a BSc or a master's programme, then it will be a 6-year programme. But traditionally, school leaver entry programmes are 5 years long. What the government is asking us to consider is whether that 5-year curriculum can be condensed into a 4-year programme, so that they can basically churn out graduates to enter the NHS workforce a year earlier than we currently can do. Widening participation is a very, very powerful thing on the agenda, which is that we are encouraging, and I completely subscribe to this, and Southampton has an excellent widening participation programme, but it's really all about encouraging people to study medicine from diverse backgrounds who would not normally consider medicine as a career. So widening participation is an important part of this. And allocating medical school places to areas which are traditionally under-doctored. So areas where it's difficult to recruit doctors to work, where there may be a medical school or where there's potential for a new medical school to be set up, would be given priority allocation of places. I can see there's questions coming in, but I'm presuming you're happy for me to pick those up at the end of the talk. Is that okay?
Absolutely fine.
Brilliant. Okay, fantastic. So that's the sort of guidance from the Office for Students about the basis on which they will allocate this first tranche of increased places. So just addressing the first of these, which is innovation in course delivery, I think this would be a good thing in any event, with or without expansion of student numbers. I think we need to really try and move away from lecture-based style teaching, where basically, as you perfectly well know, somebody stands at the front of the room with a slide set, there's knowledge to impart, they show the slides to the students, they talk them through, and they hope that the students got something out of it. That's not a great way of learning in a modern world. So I would hope that we could increasingly move away from lecture-based teaching in any event. However, it's cheap, it's cheerful, we all know how to do it, and I think that people feel comfortable, or certainly lecturers feel comfortable with that style of course delivery. But we really want to move more to flipped classroom delivery, where students are given materials in advance of the teaching event, such that they've done a lot of the background preparation, and then the seminar or the tutorial or the small group teaching is very much exploring their understanding of the materials that they've had to work through in advance. We do need lots more small group teaching. I think that's undoubtedly the feedback that we get from our students. They really benefit from being in an environment with a small group of peers and a facilitator where they can where you really have a chance to get to know them, to build a sense of community of learning, and to understand their anxieties and concerns about what they're being taught, so you can really explore whether or not they've grasped concepts and are able to apply knowledge and understanding to the topics that you're covering. I think as a medical school programme, we are very focused in Southampton on teaching students clinical reasoning skills right from the beginning, so that they are applying their knowledge and understanding using clinical reasoning skills and developing those skills very early on in the programme, and moving away from that sense that medical students have of just cramming facts in, spewing them out in an examination and then forgetting them almost instantly, and then they're moving on to the next bit of the programme and they haven't really retained that knowledge, and it's dubious as to whether they really have the understanding that they need to translate that knowledge into the clinical environment. So we're very keen to move to a more clinical reasoning skill-based teaching programme with less fact-based recall. Equally, we want to start, I think, teaching more clinical skills in the university setting very early on in the programme. There are basic clinical skills that you can teach using a clinical skills facility or a simulation suite. Early on, it really grasps the imagination, it really takes hold of the imagination of students to start learning practical skills early on, using mannequins, using simulated patients, such that they can take the pressure off the actual clinical placements in the NHS environment, because they're going into those clinical placements much better prepared. So you've got all of the plethora of virtual reality resources which are beginning to emerge on the market. I think there's also an opportunity, and I would love to think that we would grasp this wholeheartedly, to improve interdisciplinary learning. Many of the catastrophes that have happened in the NHS in recent years have really fundamentally been about the fact that healthcare professionals do not liaise well with each other. They are, nurses and doctors struggle still to understand their professional roles and to interact well with each other. And there have been so many cases where that's been highlighted. The Ockenden report, which was the report on perinatal mortality and excess of perinatal deaths, maternal mortality, absolutely highlighted the fact that healthcare professionals communicate with each other poorly. We can do a lot to address that if we have co-curricular development with healthcare professionals across the piece, rather than teaching healthcare professionals in silos. So those are all innovations that we can employ, but the challenges of doing this are you need more clinician input. Well, how is that going to happen in an NHS that is collapsing, really, or creaking at the seams at best? You need more staff to teach, particularly if you're going to have more small group teaching, so it's resource intensive. That's a particular problem in medical schools like mine, which is a Russell Group medical school, which are traditionally research embedded faculties of medicine or schools of medicine, where research has very much traditionally been the priority, and education sort of follows in the wake of research, if you like. So that is a big issue, particularly for research intensive universities. And we have to face the fact that the number of clinical academics, so the number of clinicians who work in a university environment, those numbers are dwindling. We are not maintaining those clinical academic numbers. In fact, we're losing them hand over fist. So how do we start to redress that? How do we start to recoup that loss of clinical academic input, which I think is vital to the health of a medical school? And we need investment in infrastructure. We need space, we need IT support in order to be able to deliver this successfully. And really, we need a sort of nice approach, if you like, to the plethora of virtual reality tech that is coming on board on the market. I mean, tech companies are seeing this as a golden opportunity to cash in. And so I'm besieged with emails from all sorts of people saying, we've got this, we've got that. And it's really hard to know where to invest your scarce resource when there's been no real evaluation of the products on offer. And I think you could risk investing a lot of money in a lot of tech that very quickly goes out of date or is not actually fit for purpose, because I don't think we've properly evaluated what's out there and can invest wisely. So that would really worry me, and that's a challenge. The bit about supporting general practice and other shortage specialties, that's also a bit of a challenge, I would say, because you can focus on primary care in your curriculum, but the outcomes for graduates 2018 has many, many, many other learning outcomes which are not directly related to primary care and which we equally need to cover and address. So it's a very comprehensive document, and any medical curriculum has to ensure that its students meet all of the learning outcomes. So it's difficult to work out how you make your curriculum primary care focused and attractive in terms of recruitment to primary care without jeopardizing other aspects of the curriculum that you need to cover. There's also the concern about availability of GP placements. You know, GPs are having a really difficult time at the moment, and so expanding the number of medical students that they take is something that would be quite challenging for them to consider. So how do we actually do that? And how do we deal with general practice in a post-COVID world where there are many, many more teleconsultations going on and less face-to-face patient contact than there was? Psychiatry may equally be a challenge. So, for example, the last 3 consultant psychiatrists appointed in my region work entirely remotely. None of them live in Hampshire. They do all of their work online, so we never actually physically see them. So how does that fit with delivering education to students? And we know, but we do know, that experience at medical school does impact on a subsequent career choice. And this relates to the length of time that you spend on placement in a particular specialty, the role models that you encounter along the way, the option to deliver student-selected units in certain specialties, and whatever your curriculum bias is. If your curriculum really values primary care, then there is a reasonable chance that your students will see that and will consider choosing it as a specialty, but it's a challenge. Just to say a little bit more about apprenticeship schemes, as I've said, this does involve a higher education institute partnering with an education trust, such that they develop the apprenticeship model together. And I'll give you more detail about one that's opening in 2024 in a moment. I've also said about developing a 4-year non-graduate entry medicine degree programme. There is no such thing at the moment. There are graduate entry 4-year programmes, but not 4-year non-graduate entry programmes. And I'll go on to talk about the apprenticeship model in a bit more detail, because Anglia Ruskin and East Suffolk and North Essex NHS Foundation Trust are the first to get off the ground with this. And they now have a programme which is advertised for entry in September 2024. It is a 5-year programme. The work roles that students will be expected to undertake include a wide variety, but can include portering, HR admin, patient advice liaison officers, discharge planners, electronic patient record trainers. So students will be performing these roles in combination with studying as a doctor, and they will have to take the same exams as medical students in universities, and they will be expected to meet the same standard. They will do 15 weeks work in the first year. It'll be full-time, and they will have 27 days of annual leave. Now, I'm neutral about the pros and cons of this programme, but I think there are pros and cons, and it will be very interesting to see how it pans out, and very happy to take questions on this. But we're not doing this in Southampton. This is just an example of another institute that is opening this year. The entry criteria, well, I won't read them all out, but you can see that they have to have ABB at A levels, including a science, or they can have done an access to medicine course, or they can have done a previous degree with a 2-1, either in a science related subject or a non-science related subject, in which case they must either have an A level in science or an access to medicine course. And all students will sit an Anglia-Ruskin situational judgment test as part of the selection process. So those are the entry criteria. I think it's really important, and I speak as a practicing clinician, to understand the context in which all of this is expected. You've got an NHS in crisis, and it is in crisis. I really, really think it is in crisis, and I don't think that's overstated. And you've got unprecedented industrial unrest. And the junior doctors, the BMA Junior Doctors Committee has just received a mandate from its membership for further industrial action. So this is not over, and we've had weeks and weeks and weeks of industrial action, which is having a really profound effect on our ability to deliver basic patient care, but also education to our medical students. So this is the context in which all of this is being expected to be delivered. We also have a shortage of GPs. So we're hoping to attract people into primary care by offering more high quality primary care placements in expanded medical schools, and yet we have an NHS GP shortage. So it's difficult to know how we are going to make that work. And we have a leaky bucket, so there's no point pouring more water in unless you've repaired the leaks. And we do have very significant leaks. I'm already talking to medical students, many of whom say they'll graduate, they'll do their foundation programme, and then they are already planning to leave. So this is not at all uncommon, and I equally hear this from students in allied health professional degree programmes. And junior doctors are planning their exit strategy, and senior medical doctors are retiring early if they possibly can. So I would argue that you need to fix the leak before you try and pour more in. And for me, I would say one of the biggest challenges in all of this is we must not lose sight of the student experience and student well-being. And from my perspective, it would seem that everything about this document, everything that comes from government, Department of Health, Office for Students, NHS England, does not focus on this nearly enough, if at all. And I'm really, really worried about this, because there is a rising tide of mental health problems amongst our student population, particularly amongst our medical student population. And I cannot see that shortening the course or making students work alongside trying to complete a medical degree programme with assessments that they have to pass to register with the GMC is in any way going to allow students to remain well and happy and fulfilled. And so I think we are potentially building up a real crisis in terms of student mental well-being and student experience. And nobody is talking about that other than the people that deal with students on a day-to-day basis. So this feels like push them in, push them out, get them into the workforce with no sense of the impact on their physical or mental well-being. And I think that that is a disgrace if that is allowed to happen. So it's for people like me to champion the students in all of this, because their well-being is of such crucial importance. I also have to think about my NHS colleagues in NHS placements and the capacity of NHS placements, because no matter how good your virtual learning environment is, no matter how good your simulation and your clinical skills facilities and your small group teaching on campus, All of those resources can be excellent, but the students still need to go on the ground at the coalface and do it for real. And I'm very worried about the capacity of the NHS to deal with that increase in medical student numbers and all of the other healthcare professions which are increasing alongside. I'm also really worried about the very toxic debate that's going on at the moment with physicians associates and medical students, because I think that is political hot potato. It's not been resolved. And I think that, you know, the role of the doctor, the role of every other healthcare profession needs to be really clearly defined and agreed so that everybody can play nicely together and be productive and work together for the benefits of patients. And I think we're losing sight of the fact that that debate is raging and we must fix it before we add to the problem. I do think we need to evaluate all of the digital and virtual learning resources that are out there. We need to be mindful that we absolutely need to meet the professional regulatory requirements of our regulatory body, and that's the GMC for us. And we need to be mindful that we've got a common exam at the end of all of this, which is the new National Medical Licensing Exam that our students need to pass wherever they train and however they train in order to be registered with the GMC and to practice as doctors. We've got new medical schools coming on board. So we've got the King's campus opening in Portsmouth in September 24. We've got the Cumbria campus in partnership with Imperial, which is opening in 2025. So we've got new medical schools coming in with new curricula who are all part of the mix when considering how we're going to deliver this. And my last slide, I hope I haven't gone over time, but my last slide is a really important document which I think is well worth reading, and it's a consensus statement from Universities UK, which sets out the 5 conditions that need to be met in order for us to successfully deliver this. And I don't think we've met any of them, and I don't think we're close to meeting any of them, if I'm honest, which is a strategic shift within higher education to expand health education capacity. I think we're sort of partly doing that in that new medical schools are opening, but I think that's because universities are very keen to have medical schools because it's a prestige item. But I think they have to be mindful of the fact that they consume resources hand over fist. So you need to use the resource to develop the staffing and the infrastructure to support delivering a programme, which is delivering an excellent student experience. There does need to be a culture shift within the NHS such that the educator role is valued and that learners are supported and encouraged in the NHS environment. I think we all of the healthcare professions need to get together to agree a common roadmap as to how to implement this. So there's no point medicine doing their bit separately from nursing, physicians associates, physiotherapists, OTs. We all need to agree. We've never historically done that. We've always worked in silos, and it's incredibly challenging to break that way of working, which is historic. The funding really needs to be sustained over the whole lifespan of this project, not just a sort of an initial dump of money and then the money evaporates. And as far as I can see, they've already said there's no capital investment to support infrastructure to implement the long-term workforce plan. So, you know, how is this going to be done without a substantial hike up in resource? And the regulatory, all of the regulatory bodies need to align. There's no point having, you know, having to work towards the GMC's regulatory functions, the university's regulatory functions, Ofsted, if you're offering an apprenticeship model of training, all of these regulatory bodies, they're all hoops that the individual education providers have to jump through in order to get a programme approved. Actually, what they need to do is coalesce and have a common regulatory framework, but we're about 1 million miles away from that as well. So I think that's my talk done, and I'll stop sharing, and then if there are questions, I'd be very happy to try and answer them. But that was a bit of a roller coaster through. I hope that was what you were kind of expecting.
Sobering, clear-eyed, very, so thank you. I'm terrified, but thank you.
That's a pleasure. I have to say, I don't know why, but you're very quiet. I'm going to see if I can turn the volume up.
Okay. I'll try and
I'm
speak
not sure. I think I've got it on maximum. So if people have a question, we can either take them from the chat or just shout at me, and I'll try and hear.
Well, I'm going to pass to Sam to pull the questions out of the chat to ask you, and maybe the sound will come better through from her. But lots of questions, so thank you very much, Sam.
Pleasure.
Please.
Yeah, I mean, lots of observations and, you know, concerns exactly matching, you know, what you've outlined. So I guess the first lot of questions were about the concern about condensing down the length of the course.
Yeah, well, I'm very concerned about that. I do not think, this is my personal opinion, I do not think a 4-year non-graduate programme is appropriate unless you are getting people who have a body of experience from having worked in the health service but may not have got a university health related degree. I think it might be possible then. So I think mature people who have a background in healthcare may be appropriate for a shortened course. But I think taking school leavers onto a 4-year programme, my view, that would be a mistake. Because I think there's an awful lot, you know, people who are thinking about this, I suspect are thinking about it in a very, what can I say, restricted way, I suppose, in terms of, you know, there's a curriculum, there's a lot of facts, you just need to take some of those facts out, deliver a denuded curriculum with relevant facts, get all the irrelevant niche stuff out, and it will be fine. It won't be fine because there's the hidden curriculum, and the hidden curriculum, it's all about developing those professional attributes, those professional skills, which take time. And it takes time for those students to mature. You will all know, I'm sure, the difference between a student in an early years of a programme and the later years of the programme is profound. And there's usually a pivot point at around year 3 in our 5-year programme where a light bulb moment happens and they suddenly get it. But for some of them, it takes longer. And I would imagine that if you shorten the programme and try and cram it in, you will get high fail rates, high numbers of repeat years, and ultimately you should have just spent longer in the first place and got it right first time.
Yeah, okay. I think quite a lot of agreement with that view. This is kind of bringing together a couple of comments and observations. So with what you outlined, a lot of you said yourself, a lot of it is resource intensive and needing more capacity, but a couple of questions about maybe how you see assessment changing, and how can libraries help you to support any changes in that, and also of course the issue with more students, we need more information resources, or you know, we're going to have more licensing issues to deal with the extra students.
So I hope I've heard you correctly. I mean, I think the way that our library services have helped us, and they have helped us very greatly, I think, is helping us look at the resources that are out there to support virtual learning, online learning, the resources that students can use and tap into to prepare themselves for aspects of the programme, and not investing money unwisely. So I think our library colleagues have been really helpful in terms of helping us evaluate the resources that are out there and steering us away from things that look very lovely on the surface but are incredibly expensive and actually won't be used. So I think it's about helping us with that, maybe that research into what resources will really bring maximum benefit to our students, because you can overload them. You can pile resources in, but what they really need is structure and signposting to help them navigate the way around these resources and use them effectively. I mean, it was so much simpler in my day. I had a copy of Kumar and Clark, a copy of the Oxford Textbook of Medicine, some old surgical thing I can't even remember the name of, but it was, you know, lots of horrible pictures, and the Atlas of Anatomy, and you know, I had big books. That's why I had big books that I kept in my room, but everybody had the same, and the lecturers knew what was in them and could help you navigate your way around. What happens, and I mean, I'm past it really, but now what happens is that they have all of these online resources that they find for themselves, And a lot of the stuff that they use to support their learning is stuff that we never see. And we you know, there's no sort of quality control over it. So I think it's helping us navigate that world of online resources and trying to make it make sense for the students so that they can navigate their way through it and use it effectively rather than being totally overwhelmed by it.
Yeah, and I think, Isla, you've put a question in that kind of allies to that. You know, like you said, there's so many resources out there, so much IT and AI tech out there. If different medical schools are, and I guess it happened to a certain extent now, but if different medical schools are going down different routes on buying different tools, you know, if one turned out to be better than another, then you've got that inequity.
Yeah, and exactly. And I mean, I do think medical schools are quite good at networking. You know, we have the Medical Schools Council Education Leads group, which is really good. And you know, and there's lots of different working groups. So there's a digital technology working group. You know, there will be all sorts of people getting together, inviting expressions of interest from medical schools all over the UK to participate and share good practice. So, you know, the digital learning groups, I think, going to be really, really helpful, because that's about sharing examples of good practice. So particularly live streaming, you know, one big thing which is coming through is live streaming clinical encounters in placements to a group of students that are remote. So the students will have a facilitator with them, but they'll be live streaming a ward round or a clinic or an operating list. I mean, obviously the whole data protection issue and consent and everything all has to be carefully worked through. But it's a brilliant way of accessing the clinical environment really efficiently. So, for example, if you have a cancer multidisciplinary meeting, you've got an oncologist, a radiologist, a pathologist, a surgeon, a physician, all in a palliative care nurse, a nurse specialist, all in the room together, all discussing individual patient cases. That's such a rich opportunity to learn. But if you go there as an individual student, you'll sit at the back, everyone will ignore you, you won't really follow the thread of what's happening, probably, and it will be a wasted opportunity for what could be a really rich learning experience. Whereas if you could stream that and have a group of 15 students with a facilitator who could, you know, pause, discuss, pick out bits from the MDT, you could have a really rich learning experience which could reach many more students. And you know, operating theatres, I can remember as a medical student hanging onto a retractor, holding the liver back for a surgeon for about 3 hours, not really learning a great deal, but I was a useful retractor holder. Now, if you live stream the operation, the surgeon can potentially talk, a facilitator can be with a group of students, you're not in the way, you don't have to suffer the anger of a theatre nurse when you don't scrub up properly or you sneeze into somebody's open wound, or, you know, it's a really good opportunity for enhancing the student experience. But we need to learn from each other and learn what works.
Yeah, and I think that touches on a lot of other comments that are in the chat, talking about this idea of how do we support and develop interprofessional education and physician associates as well. So a question about how do you see all that working together?
Well, the working together bit, if that's about interdisciplinary working, I think is really interesting. And there are some really good examples. You know, one example that I, as external examiner to Bristol, that I've seen is teaching midwifery students and medical students who are doing their obstetrics placement together in a virtual simulation environment where they are responding to various maternal emergencies. So there might be cord prolapse or massive hemorrhage or cardiac arrest in an expectant mother, you know, all the horrible maternal medical emergencies that are happening that absolutely rely on the midwife and the obstetrician working well together. And the medical students and the midwifery students go through these stations working together to get to a good outcome, which is a live mum and a live baby. And it was brilliant seeing that in action, because it made each respect the other's role made that understand the role much better, and it really brought out the need to communicate with each other. And I think if we could extend that out to other areas of the curricula, that would be really advantageous. But it's challenging to do. I mean, our health sciences is in a separate faculty to medicine, which is ridiculous, but that's how it's set up, which makes it vanishingly difficult to break down those walls.
Yeah, and that's the last comment that we've received, and it says it's from Clive, that might it become seen as inappropriate for HEIs to have medicine schools without healthcare, or vice versa?
Well, it's a really good question, I think, because there are plenty of higher education institutes that don't offer medicine. And I think actually, ideally, of course, you should be training everybody together, because we're all completely interdependent on each other. Absolutely no doubt about it. And so training everybody together is a really sensible option. I think there's a real inequity over the way NHS England allocates placement funding across the different healthcare professions. So the tariff attached to a medical student is way higher than the tariff attached to a physio or a nursing student, in a way that seems very inequitable. So one mustn't get too depressed about the scale of the task, but all of these things we need to be travelling in a direction which means we train together so that we can work together. Because at the moment we are not working together as effectively as we should be, and that's to the detriment of patients.
Yeah. Okay, I think that's probably about it for questions.
I think we could probably continue the questions and the discussion and the points for the rest of the afternoon, but thank you so much, Jane. It's been enormously informative, huge amounts of food for thought. Clearly we'll be watching with interest to see whether this long-term working plan even comes to fruition, given possible changes with a general election. Who knows what's going to come, but my goodness, something needs to happen, because the poor old NHS is on its knees, isn't it? So thank you. There's lots of appreciation coming through on the chat as well, so huge appreciation for your time.
My pleasure. Thank you very much. I will leave you to it, but thank you for inviting me, and good luck.
Thank you. Good luck as well.
Bye.
Yeah, good luck to us all. What an afternoon. Thank you so much for your engagement.